Hello and welcome everybody tonight to our special evening webinar series at the National Keratoconus Foundation. My name is Gloria Chiu and I'm happy to say that I will be your new moderator for the evening webinar series for this next coming year. My name is Gloria Chiu. I'm an optometrist and I practice at the USC Roski Eye Institute in Los Angeles, California. And I have the pleasure of seeing many keratoconus patients and certainly have a passion for this condition and offering ways to best treat patients who are dealing with this condition. So today we have a very special speaker. His name is Dr. Majid Moshirfar, and our topic for today is surgical options for keratoconus. What's new with corneal transplants? And just a little bit of background before he begins. Dr. Moshirfar is an ophthalmologist currently working in Utah at the Hoops Vision Center and Hoops Vision Center, and he is the research director at the Hoops Corneal Research Center. He completed his medical school at Georgetown University and his residency at the Illinois Eye and Ear Hospital in Chicago, and received Best Award for Best Clinical Ophthalmology Resident. He then went on to complete a 2-year fellowship in corneal transplant and refractive surgery at the Moran Eye Center at the University of Utah School of Medicine. So he is also the senior editor of the Journal of Cornea and on the editorial board of Journal of Refractive Surgery and Journal of Cataract and Refractive Surgery. So a lot of wonderful accolades here. So without further ado, I would like to introduce Dr. Majid Moshirfar. We will be taking time for questions midway, as well as at the end of this webinar. So enjoy, and I will turn it over to you, Dr. Moshirfar.
Well, thank you, Dr. Chiu. Thank you for the kind introduction. I should say good afternoon, good evening, depending where you are. And I'm grateful and honored to share my little knowledge concerning surgical options for keratoconus. This has been my passion for the last 28 years. And I'm honored to be here with our dear patients and share with them what I know, and I'm looking forward to questions afterwards as well. I do not have any financial disclosure except that I'm quite interested in this disease. I assure you, you can find family members that may have a disease. You can find, and I even have searched my own family, and I have discovered some of them with topographies that have mild or even moderate cases of keratoconus. So it runs, and it's more prevalent than we think. I think it's always important to have a little introduction. I know for some of my audience that this may be quite preliminary, but you know, our eyes, just like microscopes, just like telescopes, just like many other optical system, is a 2 magnifying lens system. There is one magnifying lens which is in front of the pupil, and then there is a crystalline magnifying lens which is behind the pupil. And both of these work in tandem to enable us to see what we see: distance, near, intermediate. But let's not forget that the cornea, which is that transparent magnifying lens in front of your pupil, in front of the color part, that tissue is responsible for 2/3 of the optical work that you do in your optical system. So 2/3 of the optical power of your eye comes from the cornea, and it's a very important magnifying power. And it can have a magnification as low as 30s to as high as 50s, depending on who has the shape of the cornea. Now, let's not forget that in keratoconics, this important magnifying lens, which we call cornea, this transparent tissue, gradually develops a thinning. And as a result, by developing the thinning and the progression of the thinning, it develops this contour shape, which becomes more bulgy. And as a result, it changes its powers and it creates this conical shape, which we call keratoconus or cone cornea. Now, one has to understand that most of these changes happens in the blue layer of the cornea shown in this diagram, which we call stroma. Stroma is perhaps the most prevalent part of the cornea in terms of tissue, and it's the part of the cornea that is responsible for the clarity, and the interweaving collagens in that part of the cornea is responsible for the transparency of that tissue. These collagens are nicely aligned in a very organized format, almost like interwoven into one another in a very organized way to create the clarity that we need to have in our cornea. So when the corneal tissue in the stroma of the cornea develops abnormality and the fibers start to have spaces between them and they stretch, that's how the pathology of keratoconus happens. And then the cornea starts to gradually lose its integrity and it loses its mechanical power, and the cornea starts to contour in an abnormal way. And by developing an abnormal way, it creates an irregularity and it creates astigmatism as a result of that irregularity. And patients realize that their visual acuity is diminishing to a point that they don't see well, and they develop further irregularity and further nearsightedness, and that's when they need to have optical aid. Now, in terms of treatments, I must tell you that I'm very happy to see that we have made huge improvement in contact lenses. I must tell you, there was a point that we did a lot of corneal transplantation, 18, 19, even 20 years ago. We did a lot more corneal transplant on patients that on those patients today, we hardly even imagine of doing corneal transplant. And that's because thanks to our optometric physicians, we have been able to offer them amazing types of contact lenses. The armamentarium of contact lenses has changed the entire paradigm of treatment in keratoconus. There are many patients that we don't even think of doing corneal transplant because they do very well with contact lenses. And going from soft to soft toric and then eventually to hybrid and semi-hybrid and scleral lenses has really changed the landscape. And we don't see as much corneal transplant, and I'm happy that I don't see as much corneal transplant than I did in the past. And sometimes I look back and I say, had we had these type of technology, we wouldn't be doing corneal transplant on many of those patients. So it's a very good time to have these type of diseases if we have them, because it's really shown that the optometric physicians with scleral lenses and specialty contact lenses and pros contact lenses and many of the others provided them such good acuity that they function very well. They are able to lead a good life and be functional for themselves, their family, and for their society. But if the condition deteriorates, and many of our patients know that this disease can still be progressive, can they get other options? Well, one of the options that we have now that we offer even to our mild keratoconic patients, a lot of our young patients, even the 12-year-olds, the 14-year-olds, and those are the patients that I really like to see if we can offer them these treatments, is collagen crosslinking. And my talk is not about collagen crosslinking, but I have to tell you, collagen crosslinking, again, has helped me not to do as much corneal transplant that I did 20 years ago. And collagen crosslinking, the beauty of it is that it creates a more strong bondage between the fibers of the cornea. So all these separations that we see in the fibers of the collagens, they need to be supported by extra cross-linking. We need to create more carbon bondage between them. And we're able to create more cross-linking between them with this new procedure, which is called collagen cross-linking, which is not technically a surgical procedure, but it is more of a chemical procedure where patients get riboflavin, vitamin B2, along with the ultraviolet light, and over a course of 1 hour, there is a chemical bondage that happens that makes the collagens more compact and creates more stability and strength to the cornea. So in a way, we can slow the disease process in the 12-year-olds, in the young generation, so that they don't have the progressive nature 10 years, 20 years down the line. And with that, we also have seen that less and less patients require to have surgical interventions such as corneal transplant. Now, when it comes to corneal transplant, before I say anything, I have to tell you that I'm always proud to say that as an ophthalmologist, we always brag about the fact that the first successful human tissue transplantation was a cornea transplant. It wasn't a kidney transplant. It wasn't a lung transplant. It wasn't a heart transplant. As a matter of fact, when we did the corneal transplant as an ophthalmology society, it took 43 years later when the successful kidney transplant was performed. So in a way, I think corneal transplantation has a certain superiority or seniority over other tissue transplantation, but it's not a competition. What's important is that the first corneal transplant was done by a doctor from Vienna, Dr. Zerm, in December of 1905. In December of 1905, this young doctor from Vienna performed a corneal transplantation on this young 40-year-old laborer, a farmer, who developed an alkaline injury to both of his corneas and needed to have transplant in both eyes. The tissue was harvested from a young teenager, a teenage boy, and the transplantation was done on both eyes. And one of the transplant took, and it became the first successful human corneal transplantation, and he was able to see with that eye. So this is a little history that I always like to share with my colleagues, and I simply wanted to share it with you concerning Dr. Zerm. On that same note, it's important to say that the concept is that we simply try to take a large portion of the cornea off with special cookie cutting devices, and then we do the same thing on the donor, and we simply take the donor tissue, which doesn't have abnormality, and replace the cone-shaped abnormality of the recipient with a new cornea. And by doing that, the new donor tissue is going to be in the place of the damaged cornea, and we simply suture them in place with multiple sutures. This format of corneal transplantation, where you simply create a cut, you remove the abnormal cornea, and then you place the cornea of the donor and suture it, is shown in this diagram. And the procedure can be as short as 50 minutes to as long as 2 hours. It can be done under local anesthesia or sometimes under general anesthesia. And the recovery can be somewhere between 1 to 3 years, depending on the complexity of the situation and prior history. And these patients usually get multiple sutures, sometimes as low as 12 sutures and sometimes as much as 36 sutures. And these sutures over time are removed from the eye, and the control of the stigmatism is performed by removing the sutures. And also patients are on antibiotics for an extended course of several weeks to a month or two, and sometimes they are on corticosteroids drops to prevent rejection of the cornea from the donor to the host for sometimes 3, 4, even 5 years. Again, depending on the situation, sometimes can be even for decades. Concerning the corneal transplantation, I must say that this procedure is done in different formats. Some surgeons may like to do it with different size. They may use different sutures. They may use running sutures that is shown in this diagram here, or they may use single sutures. As I said, sometimes 12, 16, 24, or 32 sutures are used. But what's interesting, again, I wanted to share this picture with you. This is an old cornea transplantation in a form of square. And that's because although we think that why didn't they do it in a circular format? Because, you know, when we go back 100-some years ago, we didn't have the round cookie cutting blades. We didn't have those round cookie cutters. We had to actually use our knife to create a square shaped corneal transplantation. And I've had the chance to see several of these patients myself in their 90s and 80s. And it's interesting to see that some of them were still functionally working, but it was a square corneal transplant that then gradually became a round cornea transplant. Now, nowadays, we of course use laser. We don't even use the blade or knife or cookie cutting metals, but we actually use lasers in order to do our cookie cutting. And the lasers have provided us the technology and the accuracy to do these in a more controlled way, and also in whatever depth we want to go. For example, you can use this technology to go shallower or deeper, or even deeper, or go the full thickness of the cornea transplant. So it's been exciting to be able to use technologies, specifically we call it femtosecond laser, to help us to have a better precision in our cutting technique so that we can have a better outcome and better recovery for our patient. And this enables us to maybe remove the whole cornea, maybe remove 90% of the cornea, 80% of the cornea. We don't have to always remove the entire cornea in patients with keratoconus. And having the laser application allows us to have that luxury added to the option of corneal transplantation. Now, using the lasers also enables us to have a little bit more of a jigsaw matching between the donor and the host. And what do I mean by that? For example, in this cartoon that I created, I can use my laser to basically create a very precise jigsaw pattern, and I create the same jigsaw pattern in my donor, and then I can fit them together better. And as a result, I don't have to use as many sutures. And also I can take the sutures out earlier, because now there is an ability for me to use the laser, create a very customized way of cutting the host and a very customized way of cutting the donor, and then match them to a point that they fit so nicely that we don't have to use as many sutures as we did in the past. And more importantly, it enables us to take the sutures out faster. It enables us to don't remove the entire cornea, but a portion of the cornea that's abnormal. And also we don't need to use maybe the transplant rejection medicines for a longer time, and we don't have to use the antibiotics for a longer time. So again, it gives us certain luxury that we didn't have with the old blade cookie cutting techniques. Now, when it comes to the corneal rejection, we know that the corneal rejection is highest during the first and second year. As the years go by, the rate of corneal rejection is less. And what's important is that almost 18 to 20% of the patients can get corneal rejection within the first 2 years. But what's important is that if the physician sees the patients in a timely fashion, we can almost revert most of these back to normal recovery. Almost 50 to 90% of the patient's cornea can revive from a rejection by simple administration of frequent topical steroids. And some patients may not even need to go beyond a few topical steroids. Some patients may need to have some systemic administration of corticosteroids, but I have seen in my own practice many times when we catch them within a matter of a week to 2 weeks, we can easily revert them with topical administration. Having said that, the prognosis is overall very good for patients with the new techniques, new medications, and the prompt attention that we give to our patients. Now, there is one thing that I always hear from some of my keratoconic patients that are referred to me, that why don't I have just a corneal transplant, Dr. Moshirfar, and then this way I will be 20/20, I won't need glasses anymore. Why don't I just get the corneal transplant? And I have to say, no, I really don't think that the corneal transplant is the right thing for you. I still think that if it can fit you with a specialty contact lens to get you to see 20/20 is a better thing. And then they say, but if I get the transplant, I won't need that. And I have to correct them. And I have to say to them that even when we remove the abnormal cornea that is cone shaped and replace it with the normal cornea from a donor, the shape of the cornea is such that many times the patient may still need to wear contact lens or specialty contact lens or glasses. So this is different from what perhaps the patient was thinking about. So this is a myth that I hope it was true, and that's the direction I want to go in my research. I'm doing everything in my research to see what can we do to make sure that the patients need the least amount of correction after transplant. But at this point, we are far from that. And that is why we're still at the mercy of specialty contact lenses and our optometric physicians to help us with contact lenses for patients even after transplant. At this point, I would like to take a little break and have Dr. Chiu ask me any questions if perhaps our attendees have any questions concerning the material we covered.
Wonderful. Thank you so much. The lecture is going very, very well. We do have a few questions. The first here is, how long does a transplant last, and will I need multiple transplants?
Very good question. The fact is, the longevity of a cornea transplant. I just start by saying this to you because I always share this with my students. Every year that you get older, your cornea gets older about 2 or 3 years. So when every 2 years, they get 6 years older. So the longevity of a cornea, so if somebody has a cornea for 10 years, you have to understand that that cornea is aging a little bit faster than you and me. But the longevity of the cornea doesn't have a fixed number. Depends on the number of the stem cells that that cornea had, the number of the endothelial cells that cornea has. Depends on the amount of inflammation that that cornea has. But some corneas can last 2, 3, 4. I have seen corneas that I told you lasted 8 decades. But if somebody says, what's the average longevity of a cornea? I would say in this day and age, with the standards of the eye banking, which is superb, we are using, it's about 15 years.
Okay, that's great. And you know, I agree. I've also seen a lot of patients who have had their same transplant for sometimes 2 or 3 decades. And so I think with advances in surgery and techniques, our patients have been able to do very well with transplants. So another question, you discussed the history of corneal transplantation a bit and mentioned some advancements with laser as you use to make your cuts in the cornea. How long has the laser surgery option been available?
Very good question. The depends on the laser and the type of a laser and what part of the world and what country we're talking about. But if we're talking about United States, the application of specifically femtosecond in corneal transplantation, the fancy name is keratoplasty. I would say, if I'm not incorrect, it started around 2009. And I know that I started doing them. And we still use the good old cookie cutter metals for some of our patients, but I would say about 55 to 60% are purely with lasers, but still we have 35 to 45% of our patients that we still use the good old metal cookie cutters.
Okay, thank you. And we'll probably take maybe 2 more questions until we resume your talk. And to the audience, you can still continue to enter some of your questions in the chat, and we'll get to them at the end of this talk. So another question here, are there any exciting advancements to look forward to in regards to corneal transplantation in the next 10 years?
Yes, and I hope I will be alive, I don't know, to see them. I think that the whole concept of bioengineering of human tissue, being able to grow cornea in a petri dish, being able to customize a donor tissue and then almost like a contact lens, putting it inside the patient's cornea, almost try to shelf it into the patient's cornea. Those are the areas that I think we will see happens within the next 10, 15 years, that we would be able to customize humans' corneal tissue, almost like contact lens, and then implement them into the patient's cornea. Almost think of it as a very laparoscopic LASIK surgery, something along those lines.
Very interesting. Definitely looking forward to that. And the last question before we continue is, you haven't talked so much on this topic yet, but is there any research on prosthetic corneas or artificial corneas that you're seeing or doing?
Very good question. I think we have very intelligent attendees because you guys just took the thunder away from me. My slides after this slide, they're all about those things that you guys are talking about a little bit. And my last slide actually has to do with the question you just brought, and it has to do with what we call artificial corneas or keratoprosthesis. So when I get to that slide, I will certainly discuss it. And recently I wrote a historical article about artificial corneas, which I will again share in that slide with you a little bit. And maybe National Keratoconus Foundation will invite me to come again one more time and talk about artificial cornea. Maybe that's the way to answer that question.
Great topic, and thank you for that. So I will let you continue, and then we will stop about 10 minutes before the end of the hour to resume questions. So thank you so much.
Sure. So it's interesting because the questions that was just all brought up, I will actually touch on some of those in the next few slides. My goal was not to make this a very surgically oriented talk for patients, because some patients don't like to see blood and all those things, although corneal surgery really doesn't have blood in it. But I didn't want to, I was more sensitive of the attendees who were observing this presentation. So I didn't put a lot of surgical videos concerning these things. But if you ever go on YouTube and you look my name up, you will see that I have some information concerning other surgical options, and also some great physicians have talking about other surgical option. In the next few slides, I would like to talk about rings, corneal rings. These are rings that are made of plastic material, which we call polymethyl methacrylates, or they can be made of human tissue, corneal rings that are made of human tissue. So instead of doing corneal transplant the way we just talked, instead of replacing 100% or 90% or 80% of the tissue from another donor, now let's talk about additive procedure, a procedures that we just add something extra to the cornea. And one of them is the corneal ring, or what people call entails. And then the other one that we will talk is about corneal rings that are made of human tissue, human corneal donor tissue. And we've used the word CAIRS, C-A-I-R-S, which was coined by a very good colleague of mine, Dr. Susan Jacobs. But what I do want you to know is that corneal rings can be also made of human tissue and can be used as an additive procedure. And lastly, there is a procedure that I have a lot of interest in, and I call it SLIKE. I wrote a paper about that, and others have done numerous work on that themselves. I don't take the credit for this. The idea is not mine. But imagine if we can take a tissue and we can actually place that inside the patient's cornea, almost like creating a little shelf and pushing it in there and increasing the patient's corneal thickness, strengthening the patient's corneal thickness, and making that cornea become more round in shape. So I will briefly talk about these three things. Corneal rings, these are little arc-shaped PMMA, polymethyl methacrylate material that are very inert. They don't cause rejection. Your body doesn't reject them. And people have been using these historically, even in the cataracts. So we use these material to make these corneal rings, to place them inside the corneal tissue in the half depth or 70% depth or 80% depth of the cornea. So they are not on the surface, they are also not inside the eyeball, but they are still inside the tissue of the cornea. And what is it that these corneas do? Well, I'm not a great artist, but I apologize for me trying to show this to you, but I'm trying to see if I can show you how does a corneal ring make somebody's cone-shapedness cornea rounder. So what I'm trying to show is that imagine if a man goes inside a tent and then holds his hands up. What is it that he's exactly doing? He is trying to basically, let me see if I can get back. he is trying to make that contour of the cornea, which was very cone shaped, more round. And what he's doing is, with his hands, he's pushing on the tent. So intacts or corneal rings, when we place them in the cornea, physically, that's what they're doing. And maybe difficult for us to completely visualize that, but these arc-shaped configurations that we place inside the cornea, that's what they do. And they reduce the cone shapeness to a round shape. And this is not a subtractive procedure, it's more of an additive procedure. We add something to the cornea to strengthen the cornea. And imagine if we can do the same thing, except instead of using tissue, plastic material, we use human tissue, and we take the human tissue and we try to create these little rings of human tissue from their cornea, from a donor, and do the same thing, place them in the patient's cornea. And here what you can see, Dr. Susan Jacob is showing that we can take these humanly customized tissue and place them inside the tissue of the cornea of the host in figure D and make the cornea become rounder. And what we see here is that these go around like a purse string, and just like that cartoon I showed you that the man was pushing the tent up, is going to make the cornea rounder. And by doing that, it makes the cornea have a more regular shape. I have another cartoon to show you here concerning that matter. The top line shows you my diagram of taking a donor tissue, somebody who has a cornea, and I create this washer-shaped tissue from it with a laser. And then I take this tissue and I introduce it inside the patient's cornea, which is down here. And I basically go all the way around in a tunnel that I already created with my laser. And I put this tissue here, and I go all the way around, and I go all the way around, and I create this purse string kind of a configuration to make the cornea become round. And what it is that I use a laser to do that. Now, in some part of the world, people can do this with maybe blades, but we have the luxury of using femtosecond laser, and we create that. And what we're doing is we creating the tunnel inside the donor, and then we placing this tissue and creating a little purse string around that. So these are basically just like plastic rings. These are rings made from human corneal tissue that we place all the way around in a pocket, in a channel inside the donor, inside the host from the donor. And this way we create this strengthening around the cornea. And by doing that, we make the cornea go from a cone shapeness to more of a round shape. Now, on that same note, the third surgical option that I have been quite interested in is, imagine if we can take a piece of human tissue from a donor and put it inside a keratoconus host to thicken the cornea, to strengthen the patient's cornea. The name is not important, but some people call it S-like. And what we do with this technology is that first we use a laser, we create a special tissue from the patient donor, which looks circular. Then on the host, what we are doing is we creating a little pocket, and we going inside this pocket, almost like, imagine if the cornea was a pita bread. You make a little opening, then you go inside this and you make a little opening, and then you take this salami and put it right inside here. Imagine if that's what you're doing inside the pita bread. Now, if the host is a cornea, you create a little incision, then you go inside, you create your pocket, then you take this tissue from the donor on top, you put a little mark S so that you know which direction you're putting it in, and then you ink it so it looks a little bit different color, and then gradually the ink goes away, and then you place that tissue inside the patient's cornea. And this is called basically a form of lenticule placement inside the patient's cornea. So you're creating something on the donor in a circular format, thick, and you're placing it in the host, and by doing that, you make their cornea rounder and also thicker. We do this with laser, but it can also be done manually, and some people in the world are doing this in a manual way. This is not something that I came up with. Everyone has been contributing to this, but I think this is another surgical option that hopefully one day we would be able to mainstream. And the beauty of these last three procedures is that there is really no sutures involved. As you can see, you're shelving the patient's cornea and you're putting these tissue inside their eye, inside their cornea, I should say. Now, this diagram here is showing you this piece of tissue that has been placed inside the host, and you can see it makes the host cornea thicker, and by doing that you are strengthening the shape of the eye as well. Now, this is just a picture right now, you can't see the whole thing, but I was just trying to show to my patients and to the attendee here that by doing that you can make the cornea become a lot thicker, and then this tissue will incorporate to this one, and there is no sutures involved in this. This is a way of trying to insert a donor corneal tissue inside a patient's corneal tissue and augment and strengthen the patient's cornea. Now, as one of the attendees said, artificial corneas are actually the way that many people think will replace human cadaveric tissue, especially in third world countries that the availability of human donor tissue is not present. Boston keratoprosthesis from Massachusetts Eye and Ear has been one of the most prevalent artificial corneas that we have been using. And it's interesting because when you look at the history of artificial cornea, 100 years before the human donor transplantation was performed by Dr. Zerm in 1905, if you go back to the earlier literature from France and other places, almost 100 years before that, artificial corneas was a concept that mankind was pursuing. So the concept of coming up with a prosthetic that can replace the patient's human cornea, even though it may sound science fiction, but it's not. And we already have some platforms of artificial cornea. The only thing is that the artificial corneas are not the mainstream treatment for many of our patients when they can have a successful contact lens, when they can have a successful corneal transplantation. But at the same time, artificial cornea would be the right one for patients who have had multiple failure, or they have other confounding morbidity to their eyes. Maybe they have other diseases, maybe along with the keratoconus. So artificial cornea has been here longer than a human cornea transplant. And I think one day bioengineering will be able to make these to be maybe made from synthetically in a laboratory. We may be able to even cultivate it from the patient's cornea, meaning that we may be able to take the recipients, some of the recipient's cells, grow in a petri dish, the artificial cornea. Again, it may sound science fiction and I may be making it too simplified, but that is the direction that we will see. So the attendee who talked about and asked about the artificial cornea was right, that this may be an option for some of our patients with end-stage disease. In my practice, I can hardly remember a keratoconic patient who needed this as a first line of treatment. I would say this is perhaps for somebody who has had several transplants, maybe has glaucoma with their keratoconus, maybe has had a retinal detachment with their keratoconus. So there are other diseases that we use artificial cornea for, but for keratoconus, I don't think that would be the first line of treatment. But we do have other diseases in ophthalmology that artificial cornea sometimes can be the front forerunner, and we may have to use them before we even use a human cornea. So that was a good question that the attendee brought up, and I hope that I was able to answer it a little bit for that attendee. At the end, I really, really want to thank you for giving me the opportunity to come and talk about a very technical subject, because, you know, as a surgeon, we always want to get into the technical nitty-gritty of the procedure. I really didn't want to do that in this seminar. I simply wanted to say that corneal transplant has been around, it is successful, but if we can avoid it and if we can use contact lenses, that is the way to go. That is why one of my partner fits scleral lenses for my keratoconic patients. But the opportunity for future research is enormous, and we're seeing more and more technological advancement. But if I have a family member right now who has keratoconus, and if they can stay with their contact lenses and they see very well with their contact lens, I still encourage them to stay with their contact lens. We don't immediately revert to corneal transplantation. Thank you very much for your time.
Dr. Moshirfar, thank you so much for that really fantastic and comprehensive talk. And I wholeheartedly agree with your sentiments regarding specialty contacts. I myself am a huge fan of specialty contacts, particularly scleral contact lenses. And they've done so much for my patients. And in working with corneal specialists here at USC, many of them have told me that they are doing much fewer corneal transplantations for keratoconus because contacts are enabling such good vision with good comfort. So thank you for touching upon that. So we have about 20 minutes now. You finished ahead of schedule, which is amazing. So we'll be able to focus a little bit more on some of these questions from our audience. So the first here is, I think this question is really interesting. Are there any age restrictions in doing or not doing a corneal transplant? Before you answer, I recently had a 97-year-old keratoconic patient who actually had a corneal transplant in one eye only 10 years ago. So he was 87, and his transplant is looking amazing. He's getting 20/20 vision with a scleral lens. He's very happy and comfortable. But I would love to hear your perspective. Any age restrictions for corneal transplantation?
My philosophy concerning this is that I always tell my patients, you're never too old to see. And sometimes some patients maybe in their 90s and maybe they're in their 80s. And I always say, you're not too old, as long as they are as health-wise, they're healthy to undergo the surgery and they have the family support or they have the infrastructure to help them during the recovery. I truly do not think that there is any age limitation in terms of the older age to undergo corneal transplantation. So I do agree with you that sometimes I do corneal transplants on certain diseases, not necessarily keratoconus, in people as old as, I think the oldest I've done was 102 years old.
Oh
so,
my gosh.
So I don't think, and you have to understand that, you know, you're never too old to see. And even if you can give a patient 6 months of clarity, I think it's worth it. And that's the philosophy we have for cataract surgery. That's a philosophy we have for contact lens. Imagine if you have a patient who is terminally ill with a disease and they are in hospice, but if you can fit them with special glasses for them to see their loved ones even for 6 months, why not? So I think the concept of age and surgery or age and medical intervention, I don't think there is such a thing. I don't believe in that.
Great answer. Now, what do you do with people who have cataracts and also need a transplant? How do you manage that?
This is a very good question. And people have always said, okay, I have a bad cornea for 70 years now. I need a cornea transplant, but I also have developed cataract in the last 15 years. I need a cataract surgery. Dr. Moshirfar, can I do all of them in one shebang, or should I do them consecutively? In other words, should I do them simultaneously or should I do them consecutively? And I want you to know I can sit here and talk with you about the literature and talk with you about papers that are done for simultaneous treatment of transplant and cataract and consecutive treatments for transplant and cataract. And I would say some of my very well intelligent colleagues would tell you you need to do it simultaneously. Some people may say you need to do it consecutively. And my answer is that if you look at the literature, they both have very equal outcome. For me, in my practice, in my hand, with my limited knowledge, I prefer in most situations to do the cornea transplant first, wait about 6 to 9 months before I do the cataract surgery. This is my main way of doing it. However, there has been occasions that I have done all of them at the same time. There has been occasions that I've done them 3 months apart. And there have been situations that I did cataract and then the cornea transplant. Having said that, the last thing I just told you, I do very seldom. If I see somebody who truly needs cornea transplant and cataract, most of the time, cornea transplant first and then cataract second, or together. Very rarely cataract first and then cornea transplant.
Got it. Thank you. Another question here. How do you deal with, so we have two different questions. I'm going to try to combine it. Is dry eye an issue following corneal transplantation? And another audience member commented that they developed corneal filaments after the surgery. So do you see dry eye after transplantation? And if so, how do you manage that?
Corneal transplantation causes dry eye because we do cut all the corneal nerve endings with our machines, whether it's laser, whether it's a cookie cutter, whether it's a knife. You cut all those corneal nerve endings, and then you place a donor and you suture it. So the nerves will take a long time to re-innervate the donor tissue. And even when they re-innervate donor tissue, they will never exactly have the same configuration, same population, same shape. So the fact is, dryness after corneal transplant is quite prevalent. It's worse in the beginning, it gets better as the years go by, it gets better even a half a decade later. But as a surgeon, we are quite attentive to the fact that these patients need to aggressively treat that. We also try to help them. We try to help them in modalities, not only in terms of topical medication, but also by putting plugs in their eyes, by nerve growth factors, by putting them sometimes on blood serum. And when you said that you have developed filaments after corneal transplant, you're absolutely right. There is a portion of the patients after corneal transplant that develop something called filamentary keratitis. And we don't know if it has to do with the fact that when the epithelium from the donor goes over the host and it re-epithelializes constantly, if it causes sometimes the mucus from the cells create this abnormal filaments. But not every patient after corneal transplant gets filament, but practically most patients after corneal transplant get dryness. Filament is only one type of dryness that we see. And for those, sometimes we need to physically remove them. Sometimes we need to put the patients on some special compounding medicines that we have to have pharmacy make for the patient. And sometimes we may even need to temporarily put bandage lens on the patient's cornea, but it's a dynamic thing and we have to follow the patient for it.
Thank you. So interesting question here. Can a DMEC or Desect, and maybe you can briefly comment on what that is, can those be done to revive older corneal transplants that are failing due to endothelial cell loss?
Right. So for the attendees here, we did not talk about DMEC and Desect because those procedures are not for keratoconus patients. The procedures I shared with you today, those surgical options are for keratoconus patients. But this attendee is asking a beautiful question. This attendee is asking about DMEC and Desect. Those are surgeries that we do for patients when they lose their stem cells in their cornea on the endothelial sides. They lose their endothelial cells and then they need to have DMEC and Desect. And there are many diseases in ophthalmology, in cornea, I should say, that require them to get DMEC or Desect, not necessarily for keratoconus. Keratoconus, if you have keratoconus, you don't need DMEC or Desect. But what this attendee is asking is that I had corneal transplant 20 years ago, my cornea is getting old, and now the stem cells on this cornea in the back, the endothelial cells in the back of my cornea, gradually withering away, and my cornea is swelling up because I've lost those endothelial stem cells. Now, can I get a DMEC and Desect to revive this corneal donor that I already got for my keratoconus maybe 10, 20 years ago? And the answer is yes. There are situations that we have patients who have had keratoconus 30 years ago. They had one transplant, and now the transplant still looks good, but now it's swollen. And the reason it's swollen is because those cells in the back of the cornea, we call them corneal endothelium, they're not working anymore. So the surgeon says, I can do a DMEC or a Desect in order to revive the cornea faster, but this way you can still keep the same donor that you got 10, 15 years ago. So the answer to this attendee is most of the time you can get a DMEC and Desect for patients who have had corneal transplant for their keratoconus 10 to 20 years ago. There is only one but. Sometimes when patients get it 20 or 15 or 30 years after their original transplant, the cornea may still develop abnormality, not only in the back, not only in the endothelium, but also in those stroma tissue that I showed you, all those fibers. And sometimes it's better to change the entire cornea.
Okay, good answer. So one person commented, great explanation for Intacs resolving the shape issue. And I loved your little tent and person kind of video on that. Their question was, how do Intacs resolve the thinning problem in the cornea?
And boy, we have so many intelligent attendees. They ask questions that, yes. So the answer to your question is this. It's an additive procedure. You're right. We're putting these rings in the cornea to change the shape. And my apologies for my lack of talent in my artistic video that I made there for you guys. But I was trying to show exactly when you put these rings, you make the cornea rounder. But we really haven't answered the fundamental question. How can we prevent the progressive thinning in these patients? And that is why after 28 years in medicine, I realized that we're still not answering the fundamental questions of pathologies. What can we do to stop the suicide of the keratocytes in the stroma of the cornea? What can we do to stop that? Intacs is not going to do it. Is there any way for us to prevent this progressive thinning of the cornea that happens in keratoconus? You're right, my attendee is right, that we cannot stop that by just putting simply Intacs. The cornea is continue to progressively get thinner or more steeper. And that is why we still need to address that one. That's why I said that maybe we need to put tissue in there. Maybe we need to do collagen cross-linking. Maybe we need to do a mishmash of all of these things, meaning that not only we need to add tissue, but we also need to do collagen cross-linking. And more than that, maybe we need to learn how to change the genetics of those keratocytes in the stroma of the cornea, that they don't gradually depopulate and the cornea doesn't lose all those fibers of collagens that I showed you in that basket, so that we don't have that. So you're right. You're absolutely right. None of these procedures I told you today is going to prevent the progressive thinning. All it's going to do is improve the structural normality. Is just like somebody saying to somebody, well, for Crohn's disease, if it's really bad, what do? Okay, we take a big portion of the colon, a big portion of the small intestine, and we put it back together. But we really didn't address the underlying pathology of Crohn's. Same thing here. We are doing this, we're doing that, we're cutting this, we're putting this together, we're using fancy lasers, but we still haven't addressed the underlying pathology. So the attendee's question is very good, and I'm humbled to say that we still have ways to go before we can answer that.
I completely agree. Really kind of profound comments and thoughts about the future of keratoconus. And this just really hits upon how much we don't know yet about the condition and how much more we have to learn with through research and studies and the genetics. And can we prevent the condition from developing altogether? So it's just a really, really interesting field. And I'm hoping that we will get more answers in the next several years to come. So probably one or two more questions. Does inserting human tissue, like the ones that you mentioned in your talk, have any effect on the keratoconus progression?
Well, from a surgical naive point of view, as a surgeon, we like to do things. The fact is, we do it because we think we are biomechanically augmenting the cornea. We think that biomechanically studies have shown that we are improving the structural integrity of the cornea. So my answer to your question is, well, I've been doing this. I believe in that it's actually improving the integrity of the cornea and the strength of the cornea. That is what I like to believe. But I can share with you the other side of the story. And there are people who say, when you go into a cornea and you create a shelf, you dissecting that cornea into a double decker. And then you're putting this cornea in there, or you're putting this ring in there. You basically took this weak cornea, you made it 2-story from 1-story building, and then you put this in there. And my answer is that, but I increased the thickness of the cornea. I also made the cornea rounder. What my attendee is trying to say is that, wouldn't you making the cornea weaker by creating slices on the cornea like that? And my answer is that we think the way we are doing it, in a way, we are actually helping the shape. But that is why in future we will learn more. We will learn not only putting the host and the donor tissues together, but how can we make them become a better amalgam? How can we make them become better one tissue? And I think that's when collagen cross-linking or other glue or other adhesives or other growth factors can help us to create better bondage between the tissue we just put in there and the tissue that's already there, and how can we make that better?
Great. So this is a very practical question for patients who have just had transplantation. So if there is, this recovery period, which I know can sometimes be months or sometimes even a year following keratoplasty, will one have any sort of functional vision during this recovery period? And can they be fitted with some type of correction to use during the time when their cornea is recovering and healing?
You're absolutely right. And is the recovery long? It's not practical. This is the era that we need. The patients deserve to get a procedure, be up and going. They want to function, and you do a transplant on them, and then you tell them, you need to see me next week, a week later, 2 months later, 4 months later, 8 months later, and they have to keep coming, and you're still trying to recuperate them. You're working with a scleral specialist to put the scleral lenses on. And the answer to your question is that if everything looks good, and if everything is going on the right track, there are some patients that are compliant, and we feel comfortable for them to get into the contact lens by the 4th month after surgery. So my answer to your question is, after corneal transplantation, full penetrating corneal transplantation or partial corneal transplantation, I feel very comfortable after 4 months to send the patient to get some form of specialty contact lens so they can function better. But that's not always the case for every patient. There are some patients that I think they're too dry and I can't do that. And there's some patients that their condition is still not there for them to have that sort of a fast recovery. So for some people, this poor visual recovery can continue for a year, but there are many of them that within 4 months after surgery, we fit them with contact lens, even though they still may have 80–90% of their sutures in, and then gradually the sutures will come out by the 1 year or the 2nd year. And sometimes we don't need to take all the sutures out. Sometimes we leave some sutures in the cornea as a biomechanical support.
Got it. So this will be our last question here. What are the pros and cons of ring implants versus a corneal transplantation?
You have to understand that corneal transplantation, especially if you're doing a full penetrating corneal transplantation on a young, active person who is a martial artist. And you know that if you put a corneal ring with a specialty contact lens, they're up and going, and within a matter of 2 months, they can see well. But if you do a full corneal transplant on this person, and then they go for their martial art competition and they get hit in the eye, that can theoretically rupture the cornea, rupture the eye. That can be more catastrophic. So that is why, as a surgeon, I have to always look at my patients in a spectrum and say who is broken to the level that needs a contact lens and who is severely broken that needs a corneal transplant. So we need to look at it more globally. And I always believe that we should do something that we can do another option. If we do a corneal ring, we can always do a corneal transplant. But if you do a corneal transplant, it is very, very difficult to do a corneal ring on that patient later. So it's always better to have a step ladder approach in terms of risks versus the benefits.
Got it. And just one more follow-up question. How soon after a corneal transplant can one resume kind of more active exercise and activities such as resistance and weight training?
So if you look into the literature, you won't find a consensus. I was taught that when patients get corneal transplant for the first 3 months, they should not do strenuous activities. But what is strenuous activity? And also, we don't know exactly what amount of weightlifting somebody is talking about and what amount of exercise and tension exercises people are, resistance exercises people are talking about. But if somebody learns how to use their core, meaning that they have learned how to use their core and not their face when they do heavy weightlifting. And actually, that is one of the problems we see sometimes, patients who do heavy weightlifting, and there is old literature that says people who do heavy weightlifting, if they don't learn how to use their core muscles, they can actually increase the intracranial pressure, they can even increase the intraocular pressure, they can cause even some exacerbation of keratoconus. So first of all, we need to teach our patients how to use their core. But the answer to your question is I usually don't let my patients do strenuous exercises, meaning that I don't want them to lift more than 40 pounds for the first 3 months. Now, you have to understand young people heal faster, but still for the first 3 months, I do not like my patients to lift more than 40 pounds. But if they're working with machine and if they know how to use their cores, they can start resuming their lower extremities within a matter of 6 weeks, upper extremities within a matter of 12 weeks.
Great. Thank you for that very helpful practical advice. And I just wanted to thank you so much for your time, your expertise, this wonderful talk that you have put together for the National Keratoconus Foundation. And just thank you so much for spending this evening with us. And I just want to thank all of our attendees for joining us again during this evening webinar. And our next evening webinar will be on November 9th, 2021, so in 2 months. The topic will be Coping with Chronic Eye Disease by Dr. Greg Pusatari, who is an optometrist. So thank you everyone for attending. Thank you, Dr. Moshirfar, for your expertise and your time. And I hope that everyone has a wonderful evening. So thank you again. Have a great night.
Thank you. Thank you for the opportunity.
Thank you so much.